Wonderful. Okay, so we would like to begin by acknowledging that we meet on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. We're having lots of really important conversations about sustainability today, so it's really important to acknowledge where this meeting is taking place, and I'm speaking on behalf of McMaster and the team, as this is where Myles and I initially are. Myles, I'd like to open the floor for you. And
okay, Lisa, can you hear me okay?
Yes, I can hear you well.
Okay, excellent. All right, so I'm Myles Sergeant. I'm a family doctor in Hamilton, and I do a bit of family medicine and a bit of hospitalist medicine. Less and less as time goes by because I spend most of my time on sustainability. Next slide, please, Lisa. And I'm hoping to not speak for too long today. People get tired of hearing me speak, but I do want to speak a little bit about question number 3. Why is question number 3 even on our Green Office Challenge? This is question 3, end of life care. Essentially, are you looking at that in your office and goals of care, and is there a substitute decision maker, etc.? Next slide, please. I think I'm preaching to the converted here, so I didn't put in many of my climate slides, but this is one that I always put in. If you do life cycle analysis, which carbon footprinting of a mask does not have a big carbon footprint. Big deal. Next slide. And this is why it's a big deal. This is one breast reconstruction surgery, which is a major surgery. And this is Maria from the Netherlands, who's an artist, and she asked for her surgeon to keep all the waste from the one surgery. And that's why a mask is a big deal. Next slide. And as we all know here, healthcare, we contribute to the greenhouse gases in our country, 5%, and then the greenhouse gases in turn impact our health. And these are all photos from around Canada in the past 3 years. Next slide. This is the low-hanging peach tree. Lisa and I are working on one for family medicine. This is for hospitals. This is for a 200-bed hospital. We really emphasize that if you're going to take the time and energy to do this work, please go after the big fruits. And those are the orange ones in a hospital, the ones that have over 100 tons of CO2 per year. A couple of yellow ones on there between 50 and 100, and the green ones. They are all important, but we need to knock off some of those orange ones. Next slide. And as we all know, environmental sustainability does align with excellent patient care and aligns with an efficient system and aligns with cost savings. Next slide. I've started to ask this at most of my talks. Often in the first minute, takes people by surprise. Where do you want to be when you die? I'm not going to survey this group, but I do ask the question. I say, who wants to die in hospital? I've yet to have someone put their hand up. Who wants to die in a nursing home? Maybe 2 hands so far in 3 talks with a lot of people. Who wants to die at home? Everybody wants to die at home. Next slide, please. This is the study we did last year. And again, these numbers aren't a surprise, but what's surprising to me is we aren't thinking more about this. We aren't thinking more about the area under the curve for all these slides. So top left, we tried to get data from Canada, 2019, pre-COVID. In the case of the top left, polypharmacy, that's UK data from 2016. It's the best we could find. Their public health system as well. Not surprisingly, polypharmacy goes up with age. One bar is 3 or more meds. The other bar is 5 or more meds. Not a surprise. Then the next one over top right is healthcare expenditures. Healthcare expenditures cost obviously represents resources. Resources are greenhouse gas. So there is a fairly direct relationship here to greenhouse gases. A lot of health expenditure when we're babies, not a surprise. That it's when we're 45 that this curve starts to go up. Partly because of chronic disease, but I have another idea. Then we look at days in hospital here, bottom left, same little bit for a baby. Then it's flat, then it starts to rise around 45, 50. And then if you look at mortality rate, it's kind of the same curve. A little bit when we're baby, sadly, then nothing, then starts to rise at 45. I think that a huge piece of this area under the curve is end of life care. We start dying at 45, the curves and the values start to go up. Next slide, please. We looked at the carbon footprint of different facility types. In Fraser Valley, BC, they have something called mixed sites, which are hospitals with long-term care wards, essentially. But carbon footprint, this is just scope 1 and 2. Carbon footprint of a hospital, 30 kilograms of CO2 per bed per day. We'll jump down to long-term care, less than 9 per bed per day. Home care, less than 2. Laval, Quebec, similar numbers. Laval has better scope 2 numbers because they're on a perfect, almost perfect electricity grid. So hospitals 23, long-term care 3.5. You get the idea. There's a green lens to allowing people to die at home. Next slide. I'm not great at drawing on a graph here. I did my best in a black pen there, but that is the cost of dying in the final year of life. It's clearly a retrospective study. We don't know exactly when we're going to die. This is 10 years old. This looks at costs. This is a Toronto professor, does a lot of palliative care studies. This, again, final year of life. So the first pink dot on the bottom left is 360 days from when we die, then 270, then 180. Curve really starts to go up in the final 30, or well, actually, sorry, final 90 days really starts to go up. Surveys have been done. 87% of Canadians want to die at home. Over 50%. In fact, I think it's 59% of us die in hospital. Next slide. So the point that I make, and lots of people are making this who don't even think much about planetary health, we don't have enough home care. I think everyone knows what ALC days are. It is when a patient has been discharged from hospital by the physician, the nurse, the social worker, but there's essentially no place to go, so they stay in hospital. And we have 1 million of those days per year in Canadian hospitals. 18% of our acute care beds in Ontario are ALC beds. Patients who have been discharged can't go home. There's no long-term care beds. So again, Canadians want to age and die in the community, but most of us die in hospital. Helping people to age and die at home is good for the planet. And I would argue that if you were to do a sophisticated analysis, it might be one of the biggest things we can do is to change that. And we have an aging population. We're going to double the number of people over 85 in the next 15 years. Next slide. Again, preaching to the converted. Imagine if we had a robust primary care system, people wouldn't need to go to ER as often. I think we'd be preventing admissions, and certainly one of the best ways to prevent someone from bouncing back to hospital after discharge is the phone call from the internist, for example, to the family doc in the community saying, hey, your patient's going home, they're on these meds, this is the follow-up they need. You cannot make that phone call if there's no family doc to call. So we think that question 3 is important because we need to do more upstream conversations about goals of care. Next slide. After we did that Lancet article, we published this. I'm not great at popping things into the chat. Maybe someone else in the group could do that. Our end of life toolkit that we made with a couple of palliative care docs. Just quickly showing you the table of contents. So what can we do in a primary care office to get people to think more about their primary care, their advanced directives, who is their substitute decision maker, does their substitute decision maker agree with their plan, and will they support the patient? Next slide. Throwing this in quickly, this is a slide from our hospital toolkit. Leadership is super important. Someone has their, I think someone has their audio on there. This does not all fall on the plate of the family doc. I want to make that clear. And so this is our toolkit for hospitals. Next slide, please. Thanks, Fiona, popping that in the chat. We just put this out, gosh, 2 weeks ago as part of our recent Environment and Climate Change Canada Implementation Readiness Fund project. This is for hospital systems. There are about 1,000 hospitals in Canada. Some of them are a long ways along. I think about places like BC and places in Ontario, Quebec, in their journey towards sustainability. Others are just starting. We made this with the idea, if you are just starting, or even if you're far along, what are the top 10 things you can do for mitigation, which are major carbon items, are cost neutral or cost saving, and are relatively easy to implement. You don't need to tear down your hospital. And you can see that our first section, there's 3 sections to this. The first section is how do we enable patients to age and die in their community? So I want to reassure you, this is not all falling on our plate. We need to be doing this everywhere. Next slide. That's it. Thanks, Lisa. Back to
Thank you very much, Myles. Awesome. Is a small summary of this challenge and how everything went. All right, so I'd like to begin by saying that this was the very first year that we designed and shared the Green Office Challenge nationally. We shared it through multiple different platforms and received really important and great feedback about the actual challenge itself. When designing the challenge, we thought about the main areas that could be implemented into the clinical flow in primary care clinics, and that would have a really high impact and significantly reduce the greenhouse gas emissions from those practices. And of course, this Green Office Challenge is quite significantly based off of the Green Office Toolkit. Fiona, do you mind popping that into the chat as well? With all of the different sections backed up by current research. And we've also designed the questions to include 2 initiatives that are slightly more implementable into practice and one that's a little bit tougher to implement. And so that's why it was considered a bonus question. In terms of coverage, a lot of our participants that submitted the survey were from Hamilton, Ontario area. We did have some more coverage from across the other provinces too, but going forward, we hope to get more representation from across Canada. We do acknowledge this is the very first year we did this. So as with all first things, sometimes people are a little bit skeptical of actually trying something new. So hopefully by seeing the impact that this challenge has had on the clinics that have participated and the knowledge translation that this will lead to, we're hoping to see a lot more coverage geographically in the next following years as we continue to develop the challenge. This is an infographic summarizing some of the results. So as most of you who have seen the challenge, there was an option to answer yes, no, or sometimes maybe in terms of implementing each of these initiatives into practice. And what's interesting is that only some of these hard charts are more than halfway full of yes results, which means that actually a lot of these initiatives are not fully being implemented into clinical practice. And that's kind of what we found with the results from our Green Office Challenge as well. There were multiple clinics who represented a lot of these areas of sustainability in and celebrated their advancement in making their clinic more sustainable. And there were some clinics who expressed a wish for a little bit more of an approach towards implementing sustainability into their clinics. And we think that this is one of the key results of the challenge is actually its inspiration of our new and incoming Green Initiative Mentorship Program, which aims to address that specific gap. So we have a lot of clinics around the nation from this challenge we found out that are very interested in implementing green teams, implementing green initiatives, but sometimes it's a little bit difficult to know how to approach that given the differences in practices. And so what we've designed is a structured process to support clinics in implementing green initiatives, which involves being connected with a mentor who is also a clinician and who has a background in sustainability, who goes through some of our training modules that can support and provide the most up-to-date, well-rounded and research-based tools to support these green initiatives. So right now, the structure of the program is still under design. So if anyone is super inspired by this idea, as Myles and I are, please reach out, and we're always happy to chat with you about this. But right now it's looking like a 1-year program where mentees, which are clinics who are interested in getting involved in green initiatives, can be connected with a mentor who has a sustainability background. And together they design a co-mentorship process where they build an agreement, define timelines, and actually implement the initiative. There will also be room to reflect and evaluate the impact of the initiative. And then as a result of that, you become part of the Center of Excellence that we are currently building here at the Cancer Family Health Team in hopes to share tools and connect voices of different primary care practices and practitioners on the topic of sustainable healthcare. And also we're considering adding a QI component. So if anybody is interested in doing a QI project for their clinic, this is a fantastic way to achieve this goal. So without further ado, I'd also like to say a huge thank you to all of our collaborators who have supported our work. And of course, we have a lot of Hamilton support teams, but also national supporters, including the Canadian Coalition for Green Healthcare. And of course, HP, thank you so much for your support through this whole process. And Francis, I know you're on the call. I'd love to open the ground up for you to give any words or any thoughts about the challenge overall. So thank
you. Can you hear me okay?
Francis, can I just give a little intro to this?
Sure.
Francis may or may not know that, gosh, I went to medical school a long, long time ago. I went to McMaster, and one of the first days at McMaster, I was taught, don't intersect with pharmaceutical industry. Because you don't want the pharmaceutical industry impacting your choices on what you get for your patients. Makes a lot of sense. So I have not seen a pharmacy rep in 30 years. Look, they're wonderful people, don't get me wrong. But that's how I was taught. And then I came into this space, and I kind of came into this space with the same idea. And we've been approached from the coalition, the national group, people who want to sponsor us who are from, let's say, a gas company. And so we actually started like a little ethics committee at the coalition to say, okay, well, who should we have as sponsors? And essentially, I think we have about 8 sponsors on our website, and they are all companies which have sustainability as part of their mission, vision, or strat plan. And in almost every case, they've been doing this a lot longer than we have at hospitals. So my feeling is that if we at our hospitals are not doing sustainability nearly as well as these companies, I'm just not in a position to shame them. So yeah, enter Francis, who I met a few years ago, who does a lot of work on sustainable procurement, which I knew nothing about. They don't teach you that in med school. And so I learned a lot, and Francis has been involved in our sustainable procurement group, which meets every 2 months. It's really more hospital based. If the companies we buy from aren't doing a great job, knowing that procurement or supply chain is 60 to maybe 80% of our problem, if we can't work with them and do better, we have a big, big problem. So I'm going to hand it over to Francis.
All right. Thank you, Myles. And yeah, you mentioned scope 1, 2, and 3 in your presentation. Hopefully everybody knows what those are when we're talking about carbon emissions, but you're absolutely right. It's where the supply chain carbon emissions are much bigger for most organizations. For HP, it's more than 60% of our carbon footprint. So we get involved in looking at sustainable procurement from a different bit of a lens, which is when we think as a purpose-driven company, Canada's most sustainable technology company, when we look around us and we see that the marketplace is sending the signal to every other supplier, don't focus on sustainability. The way Canadians buy, whether it's governments, institutions, or even private sector companies, sustainability is very rarely included. If it is, it's a pretty dumb question like, do you have an environmental health and safety policy, which is a legal requirement, so you shouldn't be asking that. And then the scoring for sustainability performance really sends a signal back to suppliers that it's not important and they shouldn't be investing in it. Yet, when we look at the gap between what we need to invest in across Canada and to reach net zero, there's a big gap. And so we need to stimulate the small businesses, every business across Canada, just as with reconciliation. We have to get them working on carbon reduction. And the way to do that is to make it matter to them by scoring sustainability criteria in procurement. And that's why we invest in it. Very happy to help out where we can and provide leadership and expertise. And thank you for the opportunity.
Awesome. Thank you so much, Frances, for your support. And now I would like to invite some of our, I guess, stars of the show today to present some of their green initiatives in their clinic. So today we have 3 presenters. 2 of them are honorable mentions who have fantastic did a fantastic job at implementing sustainable initiatives into their clinic. I see that Dr. Carrie Reed is on the call, and I want to open the grounds to her to speak a little bit more on her clinical practice and some of the initiatives that she's implemented to become more sustainable. Carrie, can you hear me?
I can hear you. Can you hear me?
Yes, yes.
Great. I just wanted to say thanks for the opportunity to speak today, and thanks for acknowledging our clinic through this contest, I guess we call it. It's really nice to be able to acknowledge all the team members at my clinic for all the hard work that they've been doing over the last 3 years, I would say. So I just wanted to tell you a little bit about myself and my clinic. So I'm from the Beamsville Medical Center Family Health Team in Beamsville, Ontario, which is in our beautiful wine country, and just outside of Grimsby. I work in a family health team that has 9 family physicians, about 6 registered nurses, and 7 allied health professionals. We have a 2-story building with about 16 exam rooms and 2 kind of big lunch rooms / meeting rooms. We started our sort of green initiative back in May of 2021 under the guidance of Megan Davis. And we sort of gathered a couple of docs and a few of our other allied health professionals at the office and just had sort of informal lunchtime meetings and sort of started a little bit small and then have become a little bit more ambitious as time has gone by, but I still think we're at the beginning of our green initiatives. So just wanted to go through a couple of the initiatives and tell everyone what we've kind of been doing out in Beamsville. I would say we started fairly small with, trying to just reduce the amount of waste that we had in the office. So we eliminated using exam table paper and put green bins in all of our exam rooms. So whatever paper we did use, if we were doing, sensitive exams or PAPs, that we could use the green bins that way. We changed all of our cleaners to a natural, organic, time-based cleaner that is still effective against COVID and all the other things it needs to be effective against, and actually smells really nice, and the nurses are really happy with that. We did a bunch of putting green bins in our lunchroom and things like that. We changed to washable gowns from our paper gowns. And one of the best things I think that we did, in my opinion, is we got the PPE recovery bins, which has allowed us to put all of our gloves and masks and face shields into bins that come to be collected when they're full. So it's allowed us to keep a lot of that kind of waste out of landfill. We also switched all of our referral forms onto Ocean or custom forms so that we don't have to print out referrals anymore. So that was kind of the first initiative that we did, was just trying to reduce the amount of waste that we used. And then we sort of realized that there are probably bigger and better ways that we could reduce our carbon footprint. So we were able to bring in a respiratory therapist from the Best Care program who comes to our office once a week and sees all of our asthma and COPD patients and gets spirometry done and talks to them about, whether they're on the right puffers and is there a way that we can safely change them over to the dry powder inhalers. So that's been quite effective. And he's full every day that he's there and has been a real asset to us. And I find it really helpful just to be able to send all those folks there and make sure we have a proper diagnosis and good inhalers. And then we also are very lucky to have a great dietitian who is on board and is part of our family or is part of our green team at the office. So we've been able to, we have plant-based diet information in all of our exam rooms. We have a script for plant-based diets that we can easily print out or email patients from our EMR. And we often refer patients to our dietitian who are interested in, more plant-based diets. And then we added a bike rack and an outdoor picnic table to try and get some of our staff outside at lunch and enjoy the fresh air and be able to bike to work. And then the last thing that we focused on is trying to do better about the kind of tests that we order and doing a better job at cancer screening. So we have a dedicated researcher who calls people who are due for their cancer screening and who tries to follow up on any of the positive fit tests we had to make sure people have had their follow-up tests. And then with our residents that we have come through the clinic, we have a lot of chart audits where we work on deprescribing things like PPIs and benzos and antidepressants. So that kind of sums up the main things that we've done for our green initiatives. We do have some further direction that we would like to focus on. We're still unfortunately using plastic speculum, so we like to switch to metal speculums, although there's been a little bit of pushback from some of the docs. And we want to have a sort of bigger presence on our website so that our patients are aware of what we're doing and, can look up their inhalers and plant-based diets directly from our website. And so that's it. Thanks again for the opportunity.
Thank you so much for sharing all your great work, Carrie. And also the format of this meeting is also to cultivate discussion and conversation. So everyone here has an opportunity to ask questions too. Just let me know if this is something, if a question, and we're just waiting for other speaker to join. She's just running in from clinical practice. So does anyone have any questions for Carrie?
I had a quick question. What's the pushback on the metal versus plastic speculums that you were talking about?
Yeah, I mean, I think it's just personal preference. We have, out of the 9 docs, we have 4 that just really prefer the plastic speculum. So we've kind of left it a little bit and said, okay, well, we'll think about it a little bit more, come back to the next meeting, and hopefully we can sort of twist people's arms a little bit.
Just jumping in here, would you need everybody buying in? Could you do a bit of both? Does that make no sense at all?
Yeah, well, I mean, certainly that's something that we could bring back to our next meeting. I'm not sure that there's any major problems with that. I don't see why we couldn't do both. Mm-hmm. Yeah.
In our office, which you'll hear from us soon, we also are still on plastic, and it's a problem with the light. Like, we don't have strong enough bedside lights, and the plastic come with like an indwelling light.
Lisa, we might have to switch the order. So maybe you want to announce the person that we're waiting for, and that person could speak last. And
okay.
Yeah, unless you have something else to present, or no. Otherwise, yeah, we'll move on. Move on. Yeah.
All right. So our next honorable mention and I guess co-winner is Dr. Zoe Delbel-Baluz from the Hamilton Family Health Team. So she will be presenting once she joins the call. So I guess we can move on and invite our winners of the Green Office Challenge 2024 to present their initiatives. And I'm really excited to announce the St. Michael's Hospital Academic Family Health Team is the winner of the 2024 Green Office challenge. So welcome. Thank you so much for joining. And you have the floor. Tell us about your amazing work.
Thank you so much. Can you hear me okay? Great. I'm going to share my screen. I'm going to be presenting. So my name is Sarah Nestico. I'm the clinical nurse specialist with the Hamilton Family Health Team and the co-lead of our green team. I'm going to be presenting with 3 other members of the team. Lisa Liu, who's our dietitian on our team, Anne Rodriguez, who is a nurse on our team, Brenda Chang, who's a pharmacist, and we have Dr. Samantha Green on the call too, who is one of our physician champions. We put together some slides, so I will just share my screen. I want to say that we're very similar to Carrie, the work that your team has done. So it's great to hear that we're all kind of working in the same sphere. So can you see the slides okay? Great. Okay, so our team, so I guess for some context as to where we're situated, so we are a very large academic family health team in the downtown east. We are have 5 clinical sites, about 80 physicians, 30 nurses, 30 IHPs. I mean, we're a staff of probably over 200, just for context. We serve about 50,000 patients in the downtown east. So our team is made up of a group of interprofessional team members. There's about 12 of us, and we all represent the 5 different locations. We meet monthly, and we've formed kind of our what we call our green team, and we support department level initiatives across the department. We started in 2018, so we've been kind of going at this for just over 5 years. We're really happy that some of our initial work was actually getting sustainability on our strategic plan. So our strategic plan launched in 2020, so we were able to kind of push that forward. So we're happy to share that like we have sustainability both within our strategic plan and our quality improvement plan, which really does help promote and push our initiatives forward. I'm going to hand it over to Brenda Chang, who's our pharmacist on the team, who's led some of the work that we've done in MDI or climate conscious inhaler practices.
Thanks, Sarah. Can you guys hear me okay? Yes, yeah. Okay. Thanks, everyone. So I'll just walk us through briefly on some of our inhaler work. This work started roughly around the year 2022, started off with the medical resident quality improvement project. And what we decided to do for that project was to create some patient posters that we could put up in the waiting room, as well as the exam room, to kind of highlight the issue around the carbon footprint of metered dose inhalers, to sort of spark the discussion around this issue so that patients could bring the issue to their provider as they come in for their appointments, as well as a reminder for providers to think about it when they're represcribing or renewing some of the inhalers or prescribing new inhalers. At the same time, we also created what we call prescription favorites in our electronic medical record system, which are sort of pre-built orders to let us prescribe the medication. So we thought it would be a good idea for all the meter dose inhaler just to have in the shortcut name as a reminder, please consider dry powder inhalers and some examples of which ones. And then for the dry powder inhalers, some of the feedback was, there's so many inhalers, we don't know how to prescribe them. So we pre-built these orders so that all the instructions were already there. So it was easy for them to choose the dry powder inhaler. So we started off with that project, launched that project and all of those initiatives on Earth Day of that year. And we did see some significant change in one of our clinics in terms of the increase in dry powder inhaler prescribing over meter dose inhaler prescribing. And over the years, we've added more quality improvement projects with additional resident quality improvement project. A recent one that was from a pharmacy resident that looked at including a pharmacy intervention form. So the pharmacist, which is myself, would review and offer suggestions for inhaler changes. All of this work also included other things around, tools and support for this practice change. So we included an inhaler disposal policy where we educated our front desk staff and other staff within the clinic just to remind patients of proper disposal. We had presented a number of times to our teachers meetings as well as grand rounds for our teams to let them know about this issue. And we created a number of resources that are in our EMR to kind of support practice change. And as you can see in this graph here, this is data that's recently pulled from our last quarter in terms of meter dose inhaler to dry powder inhaler prescriptions by each of our 5 sites. And just to let you know, in 2022, those bars, so the blue being dry powder inhaler and the orange being the meter dose inhaler, was significantly different when we started. Pretty much double the amount of dry powder inhalers. So the orange bar would be twice as big. And over the last couple of years, you can see that most of our clinic now are sort of matching, particularly in 2 clinics. So the first 2 at 61 Queen and 80 Bond, we pretty much have similar number of prescribing for the inhalers. We are still working to improve the other sites, but those are the changes that we've seen. Next slide, please. And this is just an example of some of the tools and patient posters that we've created. So the prescription favorites is an example where the shortcut name kind of reminds people to consider first these other alternatives if you were going to prescribe a metered dose inhaler. We've included infographics and drug charts in our EMR to kind of suggest appropriate changes. And just want to give a shout out to the Southeast Family Health team because one of the infographics we borrowed from their family health team. The second infographic, where it's just a drug chart with all the green alternatives, was created in-house and is continued to be updated as inhalers get added. And then lastly, the waiting room and exam room posters, we've put them up just to give information to the patients. We also created one as a result of a pharmacy student project on proper disposal, so we can remind patients that, you know, they shouldn't be putting any old or expired inhalers into trash or the recycling bin because they don't get recycled. Best to return them to their community pharmacy so that they can be properly disposed of and collected and incinerated. So that's it from the project work around climate conscious inhaler prescribing.
All right, so my name is Anne Rodriguez. I'm one of the registered nurses at our Sumac Creek site and the co-lead along with Sarah of the Green Team. So just really quickly, I'm gonna go through some of the things that Carrie also mentioned, and that we utilize the Hamilton Family Health Team's website in terms of ideas. So even if you take a look at this picture about removing clinical exam table paper, you can see that we actually utilize the Hamilton Family Health Team's signage above to explain why there is no table paper. We started this at our Sumac Creek site, and it has spread to all our 5 sites. Next slide. And then in regards to our transportation and virtual visits, like I'll have to admit that our virtual visit, the impetus was mostly due to the pandemic, but that has helped us to continue offering that option. And we were lucky enough to secure some funding to help provide our city bikes at a discounted rate, which has been continued to be offered for the last 5 or so years, which we're grateful for. And we ensure that all our sites have secure bike storage as well, and that we encourage people to use, biking as or other forms of transportation as often as possible. And next slide. One of our very first projects earlier in the days of 2019 was to encourage reduce in energy. So we created these little signage at people's computers to encourage them to turn off their computers at the end of the day. We had a new site built for our 95 Homewood site at the West St. Jamestown Clinic, and when they were building that, they ensured that we had automatic light sensors so that when patients or staff leave the room, the lights are automatically turned off. And we applied for a city funding grant, which allowed us to provide some patient-facing webinars, 3 of them, and one of them was nature and social prescribing of time spent in nature, in which we were able to get people from CAPE to talk about the Parks RX program, as well as an amazing social worker from Sick Kids talking about the benefits of time spent in nature for young children. We also created some pamphlets and handouts about where to find nature in the city of Toronto, because we are like a downtown urban area. And then this year we encouraged and supported one of our resident projects, QI projects, to talk about increasing the use of Parks RX. And then one of our other webinars and focus is plant-rich eating, to which Lisa, one of our dietitians, is going to talk about.
Thanks, Anne. So my name is Lisa Liu. I'm one of the dietitians as a part of the Green Team, in addition to my other colleague, Serena Ung, who's also a dietitian, part of the Green Team. So we had a lot of fun over the last few years in trying to encourage and really engage staff around understanding more about plant-rich eating. It started off in 2022, where we collaborated with the Hamilton Family Health Team, and we presented a patient-facing webinar. There was about 150 attendees online, and it was really an introduction to promoting the benefits of plant-rich eating in relation to the environment and also our health. Over the last year, we started to think about ways that we could really encourage and adopt the culture around this in our clinic. So we created this poster that's posted in all of our different exam rooms and in the waiting rooms. And it's really simplified messaging around the benefits of plant-rich eating. And then there's a little QR code. So there are several different resources that people can access very easily whenever they're waiting for an appointment. Over the last year, we also really had a lot of fun with various types of staff engagement projects. A lot of them were based on potlucks that we had at all of our sites that included a plant-rich theme. And then lastly, previous slide. The last kind of initiative was one of our resident projects. QI projects involved implementing plant-rich discussions within our diabetes flow sheet. And so there are prompts that the nurses and the physicians can start conversations around plant-rich eating, in addition to resources that are embedded that could be easily sent to patients by Oceans, and a button that promotes a referral to the registered dietitian, so it's really easy. Next slide, please. And here are just some pictures of some of the fun that we've had over the year. In terms of other kind of grand rounds and presentations that we've had for staff, like Anne had mentioned, we've had several different ones. So involving nature prescribing, the promotion of plant-rich eating, the role of healthcare and climate change, and then planetary health and choosing wisely in terms of tests. And these are just some photos of some of our plant-based potlucks that we've had. At one of our sites, we had an item swap, which just involved encouraging staff to bring in anything that they had lying around at home, clothing, books, toys, really anything. And we had a few days where we opened it up to invite staff to come and take what you need, drop off anything that you don't need, and then we donated everything to charity that was left over.
Thank you, Lisa. And then just highlighting some of the work in advanced care planning. So Myles, your presentation at the beginning really reinforced that we probably could take a deeper dive into this. But over the years, there has been work again with our resident projects, but we've also had a dedicated nursing project looking at advanced care planning, having those conversations with our populations, our older populations, and increasing the number of advanced care plans in the chart. But I think, more work definitely can be done. And as we move into 2025 and thinking about what our goals are, it's something for us to consider. Just another highlight is that we have had a patient partner on our team since the beginning, and we're currently going to be looking for a new one, but we also aim to engage with our patients around sustainability initiatives. So we did these webinars 2 years ago, but we also, we will aim to annually connect with patients specifically about sustainability once a year on Earth Day. So we send out a specific Earth Day email. This is just an example of the one we sent out last year. We're excited to receive this award, but we're also excited that not beyond our family health team, sustainability is becoming a forefront action item for the hospital as well. So our hospital, St. Michael's, does a Values and Actions Awards in September, and they've recently added a spotlight on sustainability. So our team was the first team to receive that. So it's just really great news in the attention that it's sustainability is having at the hospital level. And then we're really grateful for this award, but we know we're doing this similar work to everyone else in this area. So really humbled too. We do want to highlight that we have really looked to the Hamilton Family Health team for a lot of resources and guidance. And I would say that's really helped us to get to where we are. So thank you so much. And we hope that we can kind of inspire other teams, perhaps in the local Toronto area, to take part as well. So thank you.
Thank you. Am I back on? Yeah, there I am. Yeah, thank you. Amazing work. I hope we're going to have a bit of time for questions at the end. And amazing work for all three of the top three. I think it was actually Lisa and Autumn know the results. I just know it was very tight at the top. I'll tell you that it was very tight at the top. And so we do want to hear from Zoe as well. I know Zoe from Shelter Health Network for years, and amazing to see she's doing this sort of work as well. I also want to throw out there that I did participate, and I clearly did not finish in the top three. Lisa, I want to do a webinar on Myles excuses, okay? Because I have a ton of excuses, but that'll be for another day. Zoe, do you want to take it away? Is Zoe still here? And if not, Lisa, you're going to have to do a bit of stand up. Okay. Is Zoe still here? Let me just scroll across here. Zoe here. Zoe. Looking for the Z. There she is. Okay. It just says camera off. So
there we go. Yeah. Sorry. Okay. Is my camera
Lisa
off?
doesn't have to do stand up. Okay. Thanks.
Can you guys hear me? Yeah. Okay. My camera's on. All good. Okay. Awesome. Thanks so much for including me in today and giving me an opportunity to chat a little bit about what we're doing in our little office. I missed the first couple talks, which is sad. I'm going to have to go back and watch them. I think it sounds like I missed some good information. But yeah, I'm happy to share a little bit about what we're doing at my office in Dundas, Ontario. So I'm a family doctor and part of the Hamilton Family Health team, but I work at a very small office. So we'll start off by introducing you to our office, which is like the polar opposite of the last team. So this is it. We are like 5 people. It's myself and another doctor. We each have 1 admin staff, and we have a nurse here 3 days a week. And that's it. We're very small, but we like to think that even though we're very small, we can, make a big impact through little changes that have ripple effects. I have medical students rotate through here periodically for electives, and they all get a very prompt education on inhalers and other things like that. So I'll go to the next slide.
Okay, so as with probably many offices who get involved in implementing green changes, it all started with exam table paper. I'll give a quick little anecdote. When I was in medical school in Ottawa, I did a rotation at the Children's Hospital of Eastern Ontario, where they were doing a pilot way back when about not using exam table paper. And I thought it was amazing, and I was so excited about it. And they gave education to us about it. We saw the patient-facing information about why it is a good thing to do. And I thought that's fantastic. But then I never saw it again anywhere else in medical school. I never saw it again anywhere else in residency. I did locums for a few years and I never saw it anywhere else. And when I took over my practice, I didn't have the courage or I guess, I don't know, the energy to say like, we should do this too. It's okay. Until the Hamilton Family Health team kind of gave that nudge and that sense of community and support around making this first kind of step towards change. So that's kind of how we started, and it rolled into a whole lot more things. So we'll go to the next slide. There. Okay. So trying to avoid printing and doing as many things electronically as possible has always been part of my practice. I think we've been doing e-referral and e-prescriptions for 5 or 6 years now, e-faxing 9 or 10 years. So I try to almost never print things if I can avoid it and if it makes sense. Next slide. Sometimes you have to print things like lab work requisitions, and I would love it if there was a way to avoid that, but right now there's not, and sometimes you have to print things. So we started using 100% recycled paper when we learned about the Roland EnviroCopy paper through the Family Health team's list of products that they had procured that were kind of like green approved. We started off buying it from Costco. When Costco stopped selling it, I was very sad because I had started really liking the feeling of printing on recycled paper. So we went back to the Family Health team, Green Initiative at that time, and they were so kind and found me somebody who could get us the same paper. And now we order it in bulk from a company called Spicers. And it gets delivered about once a year because we're a small office. We don't use too much. When we get our delivery, it lasts a long time. And it's actually less expensive than any other paper we've ever used. And we just feel really good about using 100% recycled paper. And then when we got rid of the exam table paper, really kind of opened the door to using an infant measuring board, which has been such a great move. And I think it results in a lot less wobble on our growth charts. And patients seem to really like it, and they get involved in the measurements and can kind of, see and double check with me, as opposed to, using the crinkled up table paper. So next slide. Another thing we started about 5 years ago or so, 4 or 5 years ago, was using organics disposal at our office. So we use it for food waste. We also use it for paper towels. After we wash our hands, the kind of like dried used paper towels. That was something that wasn't part of our office before. So I went to our building manager and my superintendent and said, can we do this? He said, sure. He got me a green bin. I promptly learned that you need to lock it. Otherwise, everything will end up in it. So if this is something you're ever considering and it's in a public space, lock it. But now it works great. And I think we avoid putting a lot of things in the garbage because of it. And I think just even having it in the staff room really helps kind of like promote and remind people, that it's important to try and reduce our waste and our carbon footprint. So that's great. Next slide. And that's a picture of actually right beside where I'm sitting right now. Under every paper towel dispenser, we have 2 receptacles. One is for paper towels only, and we have a little label that says paper towels only and the garbage. And it's great because that then just goes right into the green bin. And it also starts a conversation with patients when they're asking, hey, which one do I use? And then I can say, well, this one, because that's for just paper towels that go in the green bin. And then they kind of know that I'm thinking about it, that I care about it. And I think it just kind of like spreads awareness and energy for this kind of thing. Okay, next slide. This is the Benefect Decon 30, another item that I found from the Hamilton Family Health Committee's list of products that they procured. So it uses plant-based like essential oils from thyme and lemon to make this disinfectant. We started using it during COVID when we were doing a ton of disinfecting, and I didn't like using single-use wipes or Lysol wipes to wipe everything down all the time. So we just use paper towels that then go in the green bin with this, and it smells amazing. Yeah, so that's the Decon 30. Next slide. And then I think that really the majority of our impact comes through the time in the room with the patient. So I don't know how many times I've used the number 290-kilometer car journey for every 100 dose MDI, but I say it a lot. So I'm really enjoying starting conversations around switching MDIs in pretty much every patient on an inhaler by this point, because it's been a few years now, and explaining to them why I'm trying to do this with them and why it's important, why I care. And I think that kind of just spreads awareness, and most patients are super on board with it. And it's been a really fun way to bring kind of my passion for the environment into work. And the same with the Park RX. This is one of my favorite initiatives that I get to talk about, and it just makes work so much more joyful for me, is I get to talk about something that I love, nature time. I've been doing it for a few years, but you kind of lose momentum. And then last year I saw Dr. Melissa Lem talk about it at a conference, and I was just completely reinvigorated with all the energy to use it. So now it's in all of my periodic health check-in stamps to talk about it, to send an email with a Park RX or print one out. Every mental health visit, it comes up as an equal option for treatment with sleep and exercise, nature time, social time, and then maybe medications. But it's so much more lovely to talk about exploring new parts of the Bruce Trail or going waterfall hunting all summer than talking about your dose of X, Y, or Z antidepressant. So it's been such a wonderful way to bring joy into my work. And I think that's about it. The last thing is just thank you so much for the opportunity to talk about some of the things that we do in our tiny little office.
Thank you, Zoe. Myles, over to you.
Okay, sorry, I wasn't expecting that. Yeah, thank you so much, Zoe, and thanks to all the teams, as I've said in the chat. Amazing work, such great commitment, such great leadership. Yeah, there is a prize going out to the 3 winners. Please feel free to drop off. You can jump off in the middle of my next sentence if you like. I know it's 1 o'clock. For those who do have questions and can stick around, we will stay on for 10 or 15 minutes. And now back to you, Lisa.
Yes, well, thank you so much to everyone for attending. This has been a great experience to just be a part of the Green Office Challenge, to develop and receive all of your amazing feedback. We've learned so much from this challenge, and we will be doing this again in the following year. So stay tuned, think through your green initiatives, and expect an email from me with the next Green Office Challenge once we update it. Does anyone have any questions? I'm going to open and see. What do we have here? Feel free to your camera and ask the question in person, or I guess person as well. I don't see any questions coming in the chat.
Yeah, so Lisa, while you're waiting, did you say what the winners are going to get?
Oh, that's a great point. So our winners will be receiving a specialized wooden plaque to recognize their achievements, and also we will have a social media campaign going out on all of our platforms to celebrate your great achievements. So stay tuned. I will be in touch with all of the winners with more details on when that will be sent out. So that's
okay.
the update.
So I keep going off camera because I seem to break up when I come on. Is there a question there?
Yes,
yeah, go ahead.
So we have two questions. The first question is from Pega, and how did teams engage / get buy-in from their physicians, IHPs for their initiatives? For example, reducing exam paper. So I'll open the floor to also our winners. If anyone.
Yeah, look, I'd answer, but you don't want the answer from the loser. Can one of the winners please step up and answer that one? How did they get buy-in from their physicians? It looks like Sarah.
So at one of our sites, so our Sumac site, we actually have a few of our champions at the site. And so we found, because we are 5 sites, so we found that having the champions there was really helpful to provide kind of reinforcement as to why it was important. And then we actually just took the initiative to remove the paper and put up the signs. And so then it just became kind of part of culture. At the same time, we were opening a new site. And so we decided that we would open the new site without exam table paper and kind of start the culture that way. We aim to have it, we've pushed this at all of our 5 sites. And some still will use paper intermittently but we found that we've had really great success at 2. Ultimately, it's just about reinforcing the message and kind of helping to ensure and support people in that change management. The signs really help for the conversation around with patients as well.
Great points, Lisa. I hope you're taking notes because maybe I can do better next year. And before we get to the next question, I do want to point out, we started out calling this Green Office Challenge. We thought a lot about these questions and how many answers there would be. And we picked a really simple thing, an easy metric to go through. Some people saw the first question, which is about strat plan, and they immediately stopped and went no further. We did not mean to intimidate offices. And also we are now thinking about it as a challenge to yourself as opposed to feeling like you need to win. A lot of groups felt like, well, I'm not going to win, I'm not going to do it. But we can all challenge ourselves and hopefully get a little bit better each year. And the next question here, how do you reduce the number of low fill bins? Does anybody have an answer there? Could be Sarah again. You got an answer for that one?
I actually am not sure what the question low fill bins.
Okay, so maybe we could get more detail.
So no, I'm not.
Okay, fair. Sorry to put you on the spot.
No, that's all good.
The next one, what is the response feedback from patients when you tell them you want to switch them from a blue puffer to a green puffer? Anyone?
I can sort of speak to that a little bit. Yeah. So it depends. I think majority of the patients are really open to the idea as long as they really understand the reason for it. We've had in our family health team a select few patients who report that their response is not as quick with some of the dry powder inhaler, especially if they're using the rescue inhaler. So sometimes it requires a little bit of education with the pharmacist team to kind of encourage continued use. And there are some select patients who would want to switch back, but in our view, if we can switch the majority of patients over, we've already succeeded. So we certainly don't push the agenda and force everyone to switch over. But with education, a lot of patients are willing. And it's sort of the same around the disposal. Like we had a pharmacy student project that just looked at reaching out to our patients to ask them, do you know what to do with your old inhalers? And, overwhelmingly nobody knew. And even for staff, myself included, like we didn't know that we couldn't recycle them. And so it's just eye-opening to start the conversation and make some small changes.
Does it, I posed that question. So the emitter dose inhalers are the pressurized canisters. They will deliver the dosage with pressure, whereas dry one, they need to suck it through the mouth, right? So if the asthma patient in the peak panic situation, they cannot inhale the dry one. So I have a friend who was using that. Yeah, it is very panic situation for them to where the MDI will be very supportive compared to the dry one.
Yeah, no, we hear that. Although you would be surprised that actually some of the dry powder inhaler, you don't need very strong inspiratory strength to use. With a few exceptions, there are some that the dry powder inhaler does require stronger strength to inhale, but a lot of them actually, it doesn't require a lot of strength to inhale. Certainly in a panic situation, it's a little bit different. We do also have to keep in mind that with metered dose inhalers, even though maybe psychologically, a lot of patients feel like they will get the medications because they just push and the propellant pushes the medication into their mouth. But often, most of that is just hitting the back of their throat. It isn't going into the lung where it's supposed to be effective. So I think they're probably getting very little of the effective medication too, unless it's used well. And that's one of the reasons why we ask patients to use like a valve holding chamber or an aero chamber, because a lot of medication is actually not dispersed to where we want it to be dispersed. So again, it requires a lot of education to really educate our patients so that they know, the differences and maybe try it out some more.
Yeah, you mean to say while prescribing that, do you check the patient capability to inhale the dry powder?
So we have not, within our family health team, we haven't. Um, There are some, ability to do that, but we haven't done so. And we have to keep in mind that like a lot of, even for our COPD patients, most of the inhalers are dry powder. And a lot of those patients also have some difficulty with inspiring, deeply, but they're created to be able to be used for those patients. So we just haven't done that within our family health team to check. We sort of give them the option to, and if they voice that there's a problem with using the the dry powder inhaler, we have opportunity to switch them back.
Yeah, thanks, Brenda. Thanks for clarifying that. Yeah, Miles, you mentioned that the patient, I mean to say, a general discussion. So the patient does not need to come to the hospital to die, right? How can a patient decide that? Just a general discussion.
Well, I mean, I'm actually speaking not so much as a physician, but the fact that I've lost parents on my side and my spouse's side, and so you see what happens. And I think in every case, all four of my parents wanted to die at home, and just going through it, actually, two did, two didn't. If we as physicians let our patients know someone gets has a diagnosis of COPD or CHF or cancer, we as physicians have a rough idea of what that course is going to look like. Of course, we don't know exactly, but we know weeks to months, months to years, etc. And we can educate our patients about what the end will look like. And so that decision about calling the ambulance toward the end, it's a big decision. Often that phone call means that you're going to die in hospital. So I think there's a lot of educating we can do about chronic diseases and how the end looks for these different chronic diseases, and for people to reflect on that. And again, I think the other thing I see working in complex care, because that's where I work at Hamilton Health Sciences, I might have a patient who's had a stroke, can't speak for themselves anymore. Did they have a substitute decision maker that's representing them? In a way that reflects their values, or has it fallen to 3 or 4 children who disagree about the outcome, and it ends up, do everything, full CPR, etc. So that's the other piece of it, is letting our family know so they can speak on our behalf. I hope that answers your question.
Yeah, you mean to say that as a doctor, you know that the patient is going to die in days or months, so you recommend them, instead of staying in the hospital, it is better to take them home. They stay in their homes and with loved ones. So if it is in the hospital bed, so the less access, they cannot be with the family near and dear. So if they will, so usually even though they come, so do you declare them that, yeah, it is only the days or weeks left over like that? Those communication will be shared with the relatives as well as the patient.
Yeah, if the patient gives us permission to do that. But yeah, the language we often use, and we actually have a big, I don't know how my colleagues feel about the talks that I do, but we have a 60-bed palliative care ward at the hospital I work at, and I'm essentially saying people, don't end up there. The language we often use is days to weeks, weeks to months, months to years, because we don't know exactly when someone's going to die, and I don't know what area you're in. And we changed the name. I still want to call it CCAC. Then it's the LIN. I actually forget what it's called now. But the home care services that we send out for people might be different location to location, and hopefully where you work has solid home care services. So this is not all on us as physicians, but hopefully there is really solid home care support for people who are palliative. And so I bring this up in other circles as well from a policy perspective, that we need to put more money into those resources. Hope that makes sense.
Thank you, Myles. It explains well. Yeah.
Yeah, thank you. All righty. Did we get everything, or I think so. So Lisa, I'll let you sign off, but thank you everyone for coming, and congratulations again.
Yeah, thank you, and congratulations to the winning team, and happy weekend to everyone.
Thank you so much. Yes, thank you for joining. Thank you for staying in the great discussion that we had at the end. Let us know if you have any questions or comments. We're always happy to connect with you, and have a wonderful evening and weekend. Take care.